little bit more in detail, which probably.
We have the laptop.
Okay. Few practical things that I noted down in Sue's talking that I can help you all with. Okay. So first of all, this is normal. Cardiac output divided by VSA. It's the other way around. So don't make this mistake in the exam. In exams, this question may be asked: what is cardiac output? Cardiac index is the other way around. The VSA. So, Sushma. Okay, so pulsion is the entire device. Picco is the entire device. Picco. All right. Now, what you must understand is Picco is using two technologies. Now, I'm just going to repeat this. Some things would be repetitions, but just explain to you a little bit more in detail. Okay. So, when I say pulsion, Picco, it is a use of two algorithms to actually give you output. It is using two algorithms. Okay. So, when I say PICCO, it is using pulse contour analysis or PCA technology. Okay, PCA technology, that is pulse contour analysis, and it is also using transpulmonary thermodilution. So there are two things that they are using in Picco. The first thing that we are using is pulse contour analysis, and the other thing is transpulmonary thermodilution. Okay, what are two of these different things? This if I forget this transpulmonary thermodilution, it will still give you an output. Not this machine. Other machines are there, which are, you might have heard about flow track. You heard flow track? Have you heard flow track? Have you heard flow track? So flow track is a device where you require an arterial line. You put in a small device, a small transducer over there, which has got a software in the machine, and with that device, it will give you the cardiac output. It will give you the cardiac output, just this much. You just put one small device onto the radial arterial line or the femoral arterial line. It's a small thing, it's a small like a transducer, which you attach to a specific monitor, called as flow track monitor. It's called flow track monitor, which works on pulse contour analysis, or it is also called as APCO, or arterial pulse contour analysis. Analysis software. Arterial pulse contour cardiac output monitoring. That one is called as arterial pulse contour cardiac output monitoring. Basically, the mechanism is, it is looking at the arterial pulse and giving you the entire cardiac output. So this means what? How is it estimating that cardiac output? As she said rightly, it is the area under this curve that is actually determining your stroke volume. It is determining your stroke volume. However, how is it getting its cardiac output from that area under the curve? It is getting it because it is multiplying this with the demographic characters of the patient. What is the height? What is the weight? Because what is in the aorta is different from what is there in the artery. You understand? The artery is very peripherally located. It has got a reflectance that is coming. She said reflectance means what? The artery BP is going in, and then it is touching the periphery, and then reflecting wave. When you sit on a bank of a water, of a lake, and you were to hit stone like that, what will happen? Waves will go, it will hit and then come back. So the coming back wave would be larger than the wave that you're actually sending across. So that's called reflectance. So the waveform here would be different, no, from the waveform right here. If I have to say that I have to find my stroke volume from an analysis of the waveform, I need to have the waveform of the aorta. Isn't it? I have the waveform of the aorta. So I have a problem with that. I have a problem because I am putting my artery here, I am not putting in the aorta. I am putting it right here. So I need to compensate for the aorta. Second thing, what is also happening is my aorta is a larger vessel. My artery is a smaller vessel. Since my aorta is a larger vessel and my artery over here is a smaller vessel, the compliance is also changing of that vessel. No, it's a smaller vessel. So the compliance is changing. So now I need to figure out the compliance of the aorta also. Not only am I worried about the reflecting wave that is coming back, I'm also worried about the compliance, right? So I'm worried about the reflecting wave and I'm worried about the compliance. That is the aortic characteristics. Because at the end of the day, I can say that the pulse trace is the cardiac output only if it is coming from representative from the aorta. You understand? And that is the reason that I need to add some kind of a fudge factor or a computation constant to this particular thing. So it just can't be a stroke volume. I need to add a fudge factor or kind of a factor to this, a computation constant to this particular equation, which will give me the cardiac output. Am I clear on this till now? Clear? Now, this fudge factor is actually completely dependent on the iota, which is basically dependent on the demographics of the patient. It's really not measuring any compliance. Okay, so it is not measuring anything. It just says, I have looked at 20,000 individuals of different ages, different sizes, different weights, and I think that's the compliance for that iota for that particular patient. It puts up that. You understand? That's why when you put your demographics, it calculates the computation constant. Okay, it's not measured. It's not measuring the all these things. It is just telling you, okay, with this gender, this weight, and this height, this may be the aortic compliance. And since this is the aortic compliance, what you're seeing as a cardiac output is really not measured directly. It's multiplied with the computation constant, which is actually derived from large scale studies of volunteers who have been of that different sizes. Am I clear on that? Clear on that? The algorithm is not so simple. There's a lot of things to it, but this is partly. That's why what I'm trying to drive the point home is, when you're actually going to use Picco, I need to enter the age, gender, height properly. If I don't put the age, gender, height properly, the contour analysis will not be right. Number one. But this doesn't come immediately. In Picco monitors, you need to standardize and tell the monitor that this is what is standard. To understand what is standard cardiac output monitoring, the second technology that is used is transpulmonary thermodilution. Okay. Clear on this? It's making that more calibrated. It's making that. What did I say? It's not measuring. It's actually it's just telling you this is the amount. You multiply this and this is what you're getting. Now I want to get it to be more accurate. Right? So now I'm going to say, when it is most accurate, this is the cardiac output. And how do I know when it is most accurate? When I do a thermodilution. Okay, then it looks at what I'm getting here, it looks at what I'm getting here, and then after that, whatever you're getting after thermodilution, it adjusts that and says this is your cardiac output. That's why when you do Picco, unless you do a cardiac output trace, you will not get the cardiac output monitoring. You will not get it because it doesn't take this and do it. Whereas in a flow track, it does not have this. In a flow track, it just has this. You just attach it, it will start giving you cardiac output, system, stroke volume, it starts giving you all those things. And why it gives you? Because it's actually looking at data from the age, gender, height, and then telling you this is your cardiac output. Clear? That's a flow track. Right? What this is doing? It is actually going to do a thermodilution and then tell you, okay, with this thermodilution curve, this is my cardiac output, which is the most accurate method to actually say that this is the cardiac output monitoring at the given moment. PAC is the gold standard, that is pulmonary artery catheter, which is the Swan-Ganz catheter, is actually the gold standard. It is the gold standard. Okay. This is very close to the gold standard. Very close to the gold standard. So at this moment, since PAC is not something we are using regularly, okay, this becomes our gold standard. Right? So the closest to the right cardiac output monitor is transpulmonary thermodilution, closest to the proper cardiac output. Now this is what it is telling you. It is telling you this is the cardiac output I'm doing thermodilution. Now the monitor interacts to both the mechanisms and then tells you this is what it is. Now you adjust and the computation constant changes depending on this. You understand? And that's why you have then continuous waveform which gives you continuous cardiac output. That's why then you start getting those continuous cardiac outputs. समझ में आ रहा है? Have you understood this much? Clear on this till now? Clear on this? So two different technologies, right? Two different technologies. One technology is the gold standard. The other is looking at the gold standard and telling you what the actual cardiac output is. Now, Amit, if I would ask you, now looking at this, when do you think we should repeat thermodilution? Looking at this, when do you think? Now, we've understood that this continuous value is coming only because at that given moment you've done a thermodilution, okay, and that thermodilution is it's using that thermodilution to tell you that this is your continuous cardiac output. So when you should do it? So she did mention about, what did she mention in the Every 8 hours. But is that sufficient is the question now. Now is that sufficient is the question now. Okay, she said 8 hours. At minimum, that is at minimum. That is at minimum. Like if I don't know anything, 8 hours में करूँ कि नहीं करूँ? सच में को तो गर्म पानी डालना इसमें. Is that minimum? Is that okay? What do you feel? Anyone from the audience who says that maybe I need to do it more, I need to do it here, I need to do there. Anyone? Again, I'm explaining the question to you. Okay, we have this completely depend on compliance. It is completely depend on compliance, right? This is completely depend on the compliance. Only once you have told them this is the compliance by doing this. Only once you have told them this is the compliance by doing this. Understood this much? Right. Now tell me when you would want to repeat it.
Same reading अगर है.
Sorry?
Same reading if repeated.
No. When will you do it?
Change in position and if the inotropic support increases.
That is the answer. So in the event that your vasopressor support actually changes, what is going to happen? Will change. So if you say go from 10 ml to 6 ml NORAD, 6 ml to 10 ml NORAD, you made a change in the vasopressor. What is going to happen here? The compliance is going to change. Since the compliance is going to change, you cannot now depend on the cardiac output monitoring that you are getting from here. So what do I need to do at that stage? Again repeat the thermodilution so that I can tell him, why compliance has changed. Now please look at the cardiac output again. Very important. Very important. समझ में आ रहा है? Clear on this? So which are those indications? एक हो गया that you have had a change in the vasopressors. The second is you're given a fluid challenge. You're given a fluid challenge. If you're given a fluid challenge, again the compliance will change because you suddenly put in fluid inside the artery, inside the vein. You understand? So I want to do it again. Clear? And the third is when there is a difference of more than 15%. For example, you had a cardiac output that was 1, say 2, and now it has become 2.3. Okay, now the cardiac index was 2, it has become now 2.3. It's a 15% change, isn't it? It's a big change, right? 2, say it became 3. The cardiac output I was seeing 2 all the time. Now it has become 3. It is a big change that has occurred. Is this reliable or not? That's the question. Is this right or not? Right? For that, what do? I repeat the thermodilution. So now I've given you 3 times when you need to do thermodilution. So what she said is at minimum. Is at minimum. So if it has not been done and you've really not done anything, better do it in 8 hours. It is not something that you need to do it once in so much time. You have to do it. Right? The second is when we have actually altered the vasopressors or the fluid challenge, or in short, we have altered the compliance of the vessels. Okay, so if you have reduced or you have increased your vasopressors, or if you have given the fluid and after that you've seen what some changes are occurring, you actually need to do a thermodilation. And the third is when there is a big fluctuation in your cardiac output. So you have it 2 and it has gone to 3.5. Now I need to do it. You understand? So anything that alters the compliance is what I'm going to look at. So these are the 3 ways when I'm going to do when. That is the when. That is the answer to the when I'm going to do it. Right? When. Alright. Okay. So we now have answered what is the technology.
I have one question.
Next, 1 second. And the second thing is, what have we answered?
When to
When. Yeah. Question?
The calculation of the compliance, as you mentioned, that it is calculated according to the demography that of the patient. It is weight, height.
In the APCO. In the APCO.
Okay.
In the arterial pressure contour analysis. Okay, it looks at that and then tells you the entire thing.
Okay.
You understand?
But in this, with the thermodilation, only take the compliance and then only.
That's why it's telling you the entire answer. Okay, because the algorithm there is different. The algorithm there is slightly different. So with this, it actually gives you the answer. That is why that is the gold standard. That's why that's the gold standard, right? Because that comes to the when. Okay. Now, where would you want to use this? Now let's take the example of a person who is having, who is an obese person who's come in with diabetes and hypertension. who basically has got a patch in the lung. Okay, got a patch in the lung, and the heart is Vaisa normal. Kanchan, you can go work actually, it'll be better for you. I think that's be better. Go. No, really go. Are don't listen. For that you have to is that say you have a patient, I'm going to put up a patient who is 70 years old, 72 say for example. Okay, he is having a cardiac output that is normal. His urine output is somewhere around 20 to 30 ml per hour. His blood pressure remains at 120 by 80. Okay, and he's got a lung which you saw on ultrasound which shows some kind of bilateral consolidation, or maybe it's just consolidative patch. Okay, his blood pressure has now come to somewhere around 80. What will you do in this patient? Tell me what you do in this patient. Say I have this patient, regular patient hai, kuch naya nahi hai, don't think Picco. You would think of a fluid challenge, right? That is the first thing you would think of a fluid challenge. This is the first thing you would think. Any given person will think of a fluid challenge, right? So I would decide that this is probably sepsis. He's got fever, so let me give him a fluid challenge. This is what you would anyone will think, and it is not wrong to do that. You would do that because you are considering that this patient is relatively hypovolemic because he's got sepsis. He's relatively hypovolemic, so he's got sepsis, right? That's why I need to give some amount of fluids. So I may decide to give it based on, I know that the heart is looking normal. I know that the heart is looking normal. If the heart is abnormal, it's a different condition, okay? But the heart is looking normal, I decide, okay, let me give him a fluid challenge, and by definition, it is 30 ml a kilogram. So I don't want to give 30 ml, I decided to give 20 ml. Okay, so I gave 20 ml per kilogram. So if he is 50 kilos in size, I'm giving how much? 1000 ml of fluid. No improvement of BP. BP remains at 80. Okay? BP remains at 80. Now the question comes, what do I do further? It's a vasopresses. I started vasopresses. But what is the guarantee that your fluid has been adequate before you start your vasopresses? What is the guarantee? You might find that, okay, let me see that you have started vasopresses. 2 hours later, you repeat an ultrasound and you find bilateral more B lines that have come. It has become B profiling. So it's a small amount of fluid should not cause B profiling with a normal heart. So what is the entity here? Probably what is happening here? It is leaking. It is not hydrostatic. It is leaky. Right? It is probably going to be leaky. Now you tell me, when you are in rounds, and you put your stethoscope. When leaky means it can be either hydrostatic or it can be even just hydrostatic pulmonary edema or leaky capillaries. What is your, if Gokul, if I tell you, you have a patient of pulmonary edema or such an I tell you a patient of pulmonary edema, what is the sensitivity of your stethoscope telling me there is pulmonary edema? What is the sensitivity of your stethoscope saying you have pulmonary edema? You understand what I'm saying?
Yes, sir.
So what is the sensitivity? Then how much times should we say I'm right, this is pulmonary edema? That's why I told this, that's why you're annoyed. So it's 50%, okay? It's 54% to be precise. It is only in 54% of the times that you can actually say with your stethoscope that there is pulmonary edema. Are you understanding? Only 54% of the times you can say there is pulmonary edema. But there is a larger chance to say there is pulmonary edema if I have a device that actually tells me, well, this is pulmonary edema. Right? So when I put a device in place, and I figure out that there is pulmonary edema, that device is called as Picco, or the technique is called as transpermeate thermodilution. Not only does it give me that there is pulmonary edema, it also attempts to tell me whether this is capillary leak or it is hydrostatic, whether it is because of my excess fluid or whether it is because of my capillary that is leaking, which will now tell me what is to be done apart from various other things that it can give me. You understand? Then I will decide, okay, whether I give fluid or don't give fluid. So which patient is this actually? Exactly. You understand? You understand? This is bed number 1. So this is exactly that patient where you will not know what you are doing. You understand? So you put that to this patient, you will understand, okay, what is happening to this patient. It gives me kind of an estimate, okay, this is what I need to do. Okay, similarly, which other patient have we done it for? What do we do there? We kept giving it to resuscitate it based on Picco. We resuscitate based on Picco. To an extent that we started with this resuscitation, urine output came, urine output came, whether it's going to improve, time is going to tell, but we did the right resuscitation based on a Picco monitor. Right? These are two examples of what I've tried to tell you. Why you would use it. Which are the indications? Okay, which are the indications where I would use it? Clear on this? So there are multiple indications that I would use it. I would use it wherever I am having a problem with respect to pulmonary edema. I'll have it wherever I want to use it, whether there is hypotension. Of course, it's an expensive device. That is primarily the reason that we have to be very judicious when you're going to use it. And that's why you must be very careful. If you have things that are going to improve and you're seeing it seemingly improving, why would I use it? But if I have a patient who's not improving, I'm not understanding, then I need more information. And that information I have to use to improve this particular patient. That's why I'll put in a catheter to understand what to do with it. Right? Now, Picco, let me just see what all she had written so that I can. Okay. So, we used to use the PAC. Now, we cannot forget that the pulmonary artery catheter is a fantastic device. Okay, it's a fantastic device. In which cases you will 100% use a pulmonary catheter is when there is pulmonary artery hypertension, when there is RV failure. These are two places where my Picco will probably not give me the right results. I need to have a PAC. I need to have a pulmonary artery catheter to understand when I have pulmonary hypertension. Simple? Okay. So when I have pulmonary hypertension, I require to actually look at a Swan Gans, which will give me better information than a Picco monitor. Right? Alright. Then, when you say cardiac output, when you say that number cardiac output, there is no normal value. Okay. So if a person is hyper
patient.
So when you have cardiac output monitoring, there is no normal value. You will not say 2 is normal or 4 is normal. It is normal for that time. If the person is running around and it is 7-8 liters, is different. If the patient is hyperdynamic, that is 8 liters normal for. There is no normal value for cardiac output monitoring. So that's why it's important that you trend these values. It's important to trend these values to understand what is happening to this particular patient. Yeah. Right. Now, when we are, how do we do this thermodilution? So there are certain steps that you have to follow, and you have to follow it the same way. You can't change these steps. Okay. First of all, when we are putting the Picco catheter, we are having the catheter that is going up and down. Okay. We have a central line, and we have an arterial line.
So they should always be in the opposite direction.
A good question. So what happens is that, say for example, you put it the other way around. You put a dialysis line, and you put in a central line here and an arterial line here. Say for example, or you put a central line here and the dialysis line here. Okay, something like that you do. Then there will be problems. You don't, the catheter between the central line, between the dye indication, between the indicator and the thermistor, there should not be another device. Are you understanding? Simple it is. So if the orientation of this ulta would be wrong. So if I want to put a dialysis line, I'll put my dialysis line here. I'll put dialysis line here. I will put my central line here. I will not change this orientation. You understanding? I'll put my central line either here or here and my arterial line here. Samajh mein aa raha what I'm saying? You are understanding this? So say in the instance that there are many times that you put a femoral line. Many instances what? So our orientation of the line is, if this is the person, orientation will remain as here will be the central line and here will be my Picco thermodilution thermistor. This is how it is going to be. Simple. Okay. I don't want to have any other device in the middle of this. So in short, I can't have my femoral line up because it will become middle. If I'll have to instill from here, no. Say for example, I put my central line here. Okay, and I put my dialysis line here. Okay, and my thermistor is here. Okay, now I pass my cold injectate from here. It goes all the way from here, but it then mixes with the dialysis line over here. You understand? So it will not give you the right readings. Simple. So my dialysis line should be separate, not in the same circuit of my thermodilution. Samajh mein aa raha hai? This is very important. This is very important because if you do something like that, you will have all kind of problems.
So, but we can insert right IJV CVP and right femoral Picco line. That is fine, huh? Not
That is fine
that
because
is fine.
see that what you're trying to do, you're trying to put a fluid from here which will go into the right atrium. It may be from the right jugular or left jugular. It has to go to the right atrium. From the right atrium, it has to travel from the pulmonary circulation. From the pulmonary circulation, reach the artery, and that temperature decay is what it is finding. समझ में आ रहा है?
Yes.
However, what happens if you decide to put a femoral line? For example, we had a patient now. If you are putting a femoral line, okay, femoral line. So many times it does happen that you can't put a jugular line. It does happen that one patient ko we cannot supine this patient to put a femoral to put a jugular line. It is difficult. It is very difficult. Patient niche kiya, patient starts very horribly breathing. So very difficult. So that time you have a femoral line, okay, and a femoral Picco catheter. So at this stage, there is a change in the version of the Picco where you input in over there that this is femoral. There is in the Picco big monitor, there is a place where you say this is femoral and then makes a correction factor for that femoral line. That version is called as version 3.1. It's probably not there now as of now. Okay? I don't think so. It's there on this. We will go back and search for it. Okay, we'll go back and search it. This is very latest, but we'll go back and search for it again. Okay, I didn't have the time, so I said no. Let's not just put it. So you understand this? So there is a correction factor. It need not be this orientation all the time. So if I have a femoral vein and a femoral artery, there is a correction factor that I can use. And that correction factor I is inbuilt on the software. All I have to do is just say that my line is in the femoral region. Okay, then it will give you the cardiac output. Clear? Now one more thing you must realize is, when for example you have both the lines hereby, you may have the central line and the thermistor nearby. You have a problem. You have a patient whose peripheral plasty has been done. You have a peripheral plasty being done, so you cannot really insert anything on this position because the peripheral artery has been done, or the patient is on a transvenous pacemaker or on an IVP. So it's wrong to say you can't use it on an IVP. I'll tell you how. Okay, so you have an IVP. And you have no place, here. This line is used for swan and whatever they have put for cardiac output, or when they were doing their surgery or something. There is a swan over here. There is another line over here. And there's just a sheath or something like that. So I have only this place left. So if I have only this place left, I can still use femoral artery and femoral vein. But the difference will be when you are actually doing the thermodilution, you will get a hump. You will get a hump. Why will you get a hump? Because initially वो temperature उधर detect करेगा वो area में detect करेगा वो hump. Okay, you will detect the hump and then you will get this first temperature rise and then slow rise. समझ में आ रहा है? It will show that hump. So you must be careful with this. Why will this hump otherwise occur? This hump will also occur when there is a patent foramen ovale. You understand? When there is a patent foramen ovale, what will happen is the artery you are giving to the right ventricle, and then there is a movement of blood between the right and the left ventricle, which will actually cause something like this. Okay, because something like this. So I must be certain कि भाई ये patent foramen ovale नहीं है. Okay, this is basically the hump coming from here. How can you reduce the hump? How can you reduce the hump? For example, you have femoral artery and vein. How can you reduce the hump? सोचो logically क्या करना चाहिए? If I want to reduce the hump, I want the temperature to rise slowly. What do? Or rise very less?
Inject less.
I'll remove the artery and keep it backwards. No, I'll not keep the artery line very close to the vein. See, you have an artery, right? The thermistor is lying like this in the artery. Thermistor is lying like this in the artery. For example, you have an vein. The vein is lying over here. Now this is occurring because this is the thermistor that is over here is very close to this. The thermistor is very close to this. So when I am injecting from here, the thermistor is immediately picking it up. The thermistor is picking it up, and that's why it's causing this hump over here. What I'll do, I will push this backwards. I'll get this here. So this waveform may become something like this. At least I will get a proper trace. So simple thing, practical advice when you want to do this. But provided you have the femoral version on the Picco catheter, otherwise you know how to use that. Clear on this? Any doubts? Clear? Right. So now, we understood the technology, we understood when to do it, this is why to do it, and we understood constellation as to how the constellation should be or configuration should be when we are actually having it in our devices, in our patients, right? We've understood this much. The next question is how to do it. How? Okay, so what are the steps? So let's see step 1. What is step 1? So I want to do thermodilation. I call up, you call me up and I say, Niharika calls me and says, sir, patient, I say, sir, what are you going to do? Step 1.
So for first consent.
वो तो हो गया. Let's not go to nursing issues. Step 1 on the here. Not to put the catheter, to do the thermodilation.
Okay. So first we'll connect the catheter to the thermistor.
It's already connected.
Okay.
Everything is on.
Just the
You need to do thermodilation.
Yes.
How to do thermodilation? I'm asking you. You have to do thermodilation. What do you do?
First enter the name.
वो सब हो गया है. That's when you are actually instilling the first time. Name, age, sex, all that is put. Now the procedure of thermodilation. What are you going to do?
Take cold saline or
No. So the first thing always is to see that the trace of the arterial line is proper or not. That is the first thing. You cannot do anything if the trace is not okay. The arterial trace. So you are wrong to say that I am going to do that all. So what I am going to do? I am going to check my arterial trace. सबसे पहले what I am going to do? Check my arterial trace. Because everything else will go haywire if my arterial trace is not okay. So that is what first thing I am going to do is I am going to check my arterial trace. How do I check my arterial trace? How do I check my arterial trace? Fast flush test. Okay, you do a fast flush test. A fast flush test should ring in the right way, which means that it should go up, come down and have two small bounces with the second bounce smaller than the first bounce. It should show this procedure. That is for any arterial line. We want to do a fast flush test to see this particular part, which means that the artery is ringing well, the resonance is okay, the frequency is fine. It cannot be, and it cannot be this. That is the first thing. The first and foremost thing is to get your arterial trace right. Everything will go wrong. Everything will go wrong. It will be bullshit if you're going to do. You don't want to give. See, remember this: garbage in is garbage out. Okay, garbage in is garbage out. If you give garbage, you show garbage. Garbage out will come. All your measurements will be wrong, right? So the first thing you do is what? I want to ensure that my this is very important. Okay, our nurses will not know. That's why when I say thermodilation, I want you to do it. You understand? Because so much of the decision making that we all are doing is based on those numbers, right? And if those numbers are not right, we will be foolish to do things with this particular patient, isn't it? It will be absolute foolishness. That's why when a thermodilation is being done, stand with the nurse. It's important that you stand with the nurse. We don't have one nurse. We have 45 nurses in our ICU. Every nurse is different. And that's why you need to figure out whether this nurse is doing the right thing, provided you know what is the right thing. समझ में आ रहा है? That is why it is wrong to get a thermodilation done with a nurse on its own, at least in our hospital. Okay. One of the proposed reasons why people use TPDT all over the world is because the nurse can do cardiac output monitoring and give you a call. One of the proposed reasons. Okay, that means in a hospital abroad, the nurse can do transfer thermodilation and then they call us up and say this is the cardiac output, this is what it is. So it becomes easy for the doctor. In our hospital, but that requires training, no? That requires training. That training when they go through, then they can do that. So don't assume that our nurses are completely trained. We have to ensure that this is done. Step 1. Step 2. Niharika, step 2.
Then sir we'll see the CVP trace also. We'll do
No.
zeroing.
What is the step 2? We are still on the line. Sorry?
Ensure
Zeroing. The next step is zeroing. The next step is and always zeroing. Okay, the next step is zeroing. The next step has to be zeroing. There cannot be anything different from that. The next step has to be. And what is the meaning of zeroing? Atul, what is the meaning of zeroing? What is the meaning of zeroing?
विनीत टीपीए का फोन आया उल्लास के पेशेंट है ना जो
रत्नगिरी
वो इंडियन के लिए अप्लाई कर रहे थे वो नीचे शिफ्ट
बेटर वी विल बी एबल टू डू बेटर जॉब. zeroing. तो zeroing का मतलब क्या तो Arshad? 1.5 years. Zeroing का मतलब क्या है?
Zeroing is like arterial line we keep open to it.
What is the meaning of zeroing?
Baseline here.
What is the meaning of zeroing? So we need to explain to the arterial line what is zero. Then it will tell you if the blood comes, this is the pressure. अगर उसको बताया कि ये जीरो होता है, फिर आगे से जो प्रेशर आएगा वो बताएगा ये इतना प्रेशर है. This is the meaning of zeroing. You are understanding what I am saying? It is basically educating the transducer as to what is zero. If you tell him what is zero, then further it can actually go ahead and tell you what is the pressure. समझ में आ रहा है? सचिन, you want to ask for coffee? Ask. ठीक है? पूछ लो. She's sleeping. पूछ लो. हाँ? ठीक है? Clear on this? बात जाके करो. Clear the zero? So in our category of how do you zero your patient? So the next step is how do you zero? Niharika, how do you zero? How do you zero?
So we'll put the knob to open to air and then select zero R.
No, how do you do zero? Amit?
Always from zero.
How do you do zero? No? How do you do zero? Zero कैसे करते हैं? So when you are zeroing, after you are zeroing, where should be the transducer? That is very important. At the
Heart level of the heart.
means what? Sorry?
Mid-axillary fourth intercost. Yes.
The right point of zero is 5 centimeters below the sternal notch in the mid-axillary line. Okay, 5 centimeters below the sternal notch of Louis जिसको बोलते हैं. Okay, 5 centimeters below the sternal notch of Louis. In the mid-axillary line is where you are supposed to zero and let the patient know that this is zero. समझ में आ रहा है? हाँ?
Zeroing can be done at any.
It can be done in Malad station also, but the zeroing procedure involves the zeroing procedure involves zero procedure required. Zero and leveling comes together. Okay, so whenever you are zeroing, this point, this present time of point number 2 is zeroing completes when you have leveled the place. Zeroing always comes with level. समझ में आ रहा है? Clear on this now? Any doubts till now? Clear? This is step number 2. So step number 1 is arterial trace. You are finding the trace is okay. Step number 2 is zero. Step number 3. What is step number 3? Is verification of connections. Is what? Verification of connections. Till now we were just looking at so what should be the connection? Where should be the connector be? So she showed the orientation should be perpendicular. Okay, you have a central line and a perpendicular. So you should use the most proximal tip, most distal tip to actually put in the thermodilation set. Not the one here, the one here. The first sensor has to be in the proximal port, distal port. Okay, it has to be at the distal port. Okay, usually the brown port is the distal port. Okay, the distal port. There cannot be a second three-way there. You understand? If there is a three-way attached to this particular port, there cannot be a second three-way. There cannot be an infusion running through that port. So this is completely dedicated to thermodilution. Clear on this? There cannot be a stopcock on that. There cannot be one of those needleless connections that are there. It cannot have that. So verify the position. So distal most lumen, okay, of the line with no three ways attached. Too much three ways attached in the middle because it will delay the injection process. Clear on this? Clear? ऐसा नहीं कि तुम्हारा injected housing is here and you have a three-way here and you are injecting from here. It cannot work that way. It has to be, if this is your three-way, if this is your injected thermistor, it has to be right here. Clear on this? So verification of where that device is placed properly. It cannot be in the proximal tip. It cannot be where there is NORAD going on. It cannot be where there is central line being monitored. It cannot be at that on those areas. If there is, your alternative is to actually switch off everything. One mistake that you can do is you have flushed and you convert that to a 45-degree angle. Not to do that. When you are flushing, when you are giving the thermodilation, let's come to the procedure. Okay. So verification. Fourth step is what? Why is it hot here? AC is not working. ठीक है, four क्या है? Fourth step. Fourth step is to actually take your supplies. What should be your supplies? Indicators. And what should be that?
Yeah, normal saline or dextrose cold.
So it has to be cold saline, but you can also use room temperature. Okay? So this has been done with room temperature. Time and again it is done with room temperature. There is no problem with room temperature also. But the underlying point is your delta temperature has to be more than 0.2. This is the point. Okay? Your delta temperature, when you do that, you will see one T coming over there. Okay? That T has to be more than 0.2. Are you understanding? So temperature of our normal IV fluid is somewhere around 23, 22, 21 ये रहता है उसका. So even that decay is kind of enough to actually figure out what is happening. But we would not do that. We will still use it with 8 degrees saline. Okay? We will not use it with a normal room temperature. But you must understand that it is not this way. That because what will happen is sometimes what will happen is you will not have. If you don't have, don't say first उसको ठंडा करो फिर लेके आओ. That is wrong. Okay, if you don't have, it's okay. Do it with the room temperature now. Keep cold saline inside. You'll get some breathing. We want it in urgency. We don't want to wait. So you can use it with
Normal temperature. But the delta T should be.
yeah. You just concentrate on delta T. Is the delta T coming more than 0.2?
Should be lesser than our body temperature.
Has to be. It will be. It will be.
27.
Yeah, our body temperature is always more. Unless you warm the fluid, the body temperature is always more. You understand? Always more. Our core body temperature is always more than any of the IV fluids you are using. You understand? That's why patients feel cold, no? When you give IV fluid, they feel cold because of that, right? So the how. When you are coming to the how, we are coming to what is the fluid that you are going to use. You can use either 5% dextrose or you can use normal saline. Okay, normal saline is always better because 5% dextrose will again move out of the circulation when you are going to this arm. Now the amount. How is the amount of fluid? Sorry, what is the amount of fluid?
10
So it's not like this. So whatever your intake put in the as an input when you are actually doing cardiac output monitoring, there is an input. So that input will be 15 ml. Say for example, you take 15 ml. If you have input 20 ml, you put 20 ml.
Yeah, according to
It says that
now
inject.
body weight.
Listen very carefully. Okay, irrespective of what your amount of fluid is, okay, the usual number for example, if I'm going to do in pediatrics, 20 ml in neonate will kill the patient baby. So it is 0.2 ml a kilogram. If you ask me exactly, how much is it?
0.1.
This is the actual thing you want to do. But in an average adult, you can use anywhere between 15 to 20 ml of this, and in fact higher also. I'll tell you why. Okay, so first you've understood this much that so if it's pediatrics, I have 0.2 ml per kilogram is what I'm going to use, right? If it's pediatrics, but if it's adult, whatever if I'm going to use 15 ml, if I decide to use 15 ml, I have to put it in my monitor that I'm using 15 ml. Are you understanding that I'm using 15 ml? Because it calculates my thermodilution based on the volume also of injectate that I'm giving. That equation actually has volume of injection. You understand? So if you don't give the right volume, you would get the wrong cardiac output numbers. So you have to check this also. Okay, that the volume is okay or not. Why? Because sometimes what does happen is you may not get that temperature decay. You may not get the temperature decay. That means delta T will be less than 0.2. That temperature decay is not there only and a cardiac output trace is not coming only properly. ऐसा लंबा aa raha hai. Okay, so it's not coming properly. Okay, so then what I need to do? I need to increase my volume. You understand? So I may want to give 30 ml. You understand? I may want to give 30 ml because the more the volume, the more it will detect. Isn't it? So I may want to give 30 ml, but if I want to give 30 ml, I put 30 ml and put there 30 ml. समझ में आ रहा है? You understand what I'm saying? Because say for example, you have input 20 ml and you've given 15 ml, the entire cardiac trace will become double. 10 ml अगर तुम inject कर रहे हो और 20 ml add किया है, all your RTs will become double. Because it is taking so many more volume. You understand to get to that level. So double हो जाएगा. Are you understanding? So the volume has to be rightly inputted when you're actually doing it. That's why I'm recommending this again and again. Do it yourself. If you, I'm certain you have not done it. That's why you don't know a single shit that I'm talking. You understand? Huh? समझ में आ रहा है मैं क्या बोल रहा हूँ? Huh? Clear on this? Then what is the amount हो गया? Next comes the speed. The speed here is very important. Huh? It has to be somewhere around 2 ml a second. Huh? It has to be. So for on an approximate level, less than 8 seconds, it should be inside. हाँ, less 15 ml हम यूज कर रहे हैं, तो less than 8 seconds में 2 ml per second में होना चाहिए वो. 2 ml per second. You understand? When it's 2 ml per second, the speed has to be in such a way that in less than 8 seconds our usual dilation, thermal dilation is done. Are you understanding? Huh? Less than 8 seconds. This is how it should be. Now, consistency. You have to inject it without a stop. You have to inject it without a stop. Okay. If they inject it, give it and then one more injection, give it one more injection. Again, the trace will not come. So, consistent speed. During the thermal dilation, you can't tell if fast or slow. The speed has to be consistent. The speed has to be consistent. So, it has to be done, and it cannot be too fast also. It cannot be too fast also. It cannot be too fast. So, it has to be consistently going inside, and you should get that particular trace. Right? Then, when you are doing this, you are also observing the trace. What are you observing the trace for? What are you observing the trace for? Usually, the transit of the dye to reach first time or create that first wave. Here, for example, I have first injected here, and then the dye is going inside, and suddenly the thermistor has picked it up. Since the thermistor has picked it up, this will be 5 seconds. Usually. The time to the peak would be another 5 seconds. And the time to decay would be another 5 seconds. In a normal heart. Are you understanding? In a normal heart, there is timing there. When you are doing thermal dilation, there is timing there. Okay. So you see that timing. Because if you have a normal heart and you are still getting 8 seconds and 10 seconds, all these things, means your thermal dilation में कुछ तो problem चल रहा है. Are you understanding? Or your cold cell is not okay, or the speed is not fine. So it's relevant and very important for you to actually look at the waveform. Okay, look at the waveform. Okay, that's why I say be there with that particular patient. Okay, because of 5 seconds, normal heart में देखने चाहिए, it should be okay. Because if it's an abnormal heart, this transit time may increase. That's fine. So by your first injection only you will come to know, अरे ये heart इसका अच्छा नहीं है. I think we need to do echo. I need to repeat the echo. Every time you do thermal dilation, no, you can actually figure out if my heart is okay or not. Are you understanding? So if my, in fact my earlier MTT was showing, this is 5 mean transit time जिसको बोलते हैं. It is 5 seconds. Now it has become 10 seconds. 100% there is some problem that has occurred with the heart. If my heart is not having a problem, then my thermal dilation is an issue.
Third 5-second time is measured from which point?
So from the start. So when you start and I said now do thermal dilation bolte na look. So when we start injecting, no, it immediately first gives you one small button, some small trace over here, and then the trace starts moving, and then it starts going up. When it starts going up, this should be 5 seconds.
I want third part.
Third part. So this is 5 seconds, and this when it reaches the end, it will decay. It will not come down. It will reach an inflection point. That inflection point is 5 seconds. Okay, and why?
15 seconds from the start.
Yes, that's what your arm rate circulation is all about. Your arm rate circulation is 15 seconds. This is exactly what it is. Okay, so this inflection point, it doesn't reach the baseline because then it is recirculating. It will not become 0. It will not become minus 8 degrees because उसके बाद सब blood mix हो गया है. सब blood mix हो गया है ना उसके बाद. Blood mix हो गया इसलिए 0 नहीं पहुँच रहा इधर. सब blood mix हो गया तो temperature और decay नहीं होगा. वो 8 डिग्री पहुँचने नहीं वाला है वो. हाँ ज़्यादा ही रहेगा वो. उसके नीचे वापस पहुँचने नहीं वाला है. समझ में आ रहा है? You're understanding? That's why it remains as a higher up than your baseline. समझ में आ रहा है? नहीं क्या है AC? Clear on this? So I'm going to look at my trace. So my step is to look at my trace. Clear? I want to look at my trace. Okay. After looking at my trace, I want to repeat the measurement 3 times. I want to repeat the measurement 3 times. And why do I do it 3 times? Because I want to improve the precision of my measurement.
I want to improve the precision of my measurement. And to improve the precision of my measurement, I need to do the investigation 3 times. Right. And what am I doing in those 3 times? In those 3 times, I am looking whether the cardiac output is varying by more than 15%. Okay. If it is not varying more than 15%, then I would accept those traces. So if it is 3, 3.1, 2.8, I can accept this because the variation is not more than 15%. But if it is 3, 2.4, 2.1, I cannot accept this reading. It is not possible to accept that reading. So if I am doing 3 readings and I am not getting it within 15% of each other, I will do a 4th reading, I will do a 5th reading. I will do multiple readings to get my precision right. And why is this occurring? Because your injection is not proper. This is occurring because your injection is not proper. You are understanding? Hmm? So 15% is the figure, right? Clear on this?
So sir, we get like lots of values. So which one we should like 15% we should see? Like,
Cardiac output.
cardiac output.
Yeah. We are what are we doing in TPTD? We are measuring what?
Cardiac output.
We are measuring cardiac output, isn't it?
Even extravascular index gives you a good idea if they're not close to each other.
No, cardiac output. Extravascular output is derived.
Okay.
What you are measuring?
Cardiac output. So cardiac.
At that instance you are measuring cardiac output. Right. Since at that instance you are measuring cardiac output, it is much easier to actually look at cardiac output and 15% variation nahi hona chahiye. Usko accept karo. Then the average that comes is very important. Now in that value, so this completes how to do it. How to do it, right? So it's not easy to do it. And nurses will not know all these things. Unless you do it, how will you explain how the nurses will know? You understanding? Huh? So the step starts, and you know the importance. You start by checking your arterial trace, of course after putting the demographics. Then you zero level. After zero level, you verify whether the position is right. Because very often what happens is these are those patients who have got multiple lines and multiple device, NORAD, adrenaline, vasopressin all going, and someone might have used the port because otherwise it's not being used. Also use किया रहेगा. ठीक है? So that whether it is placed in the right place. Sometimes it so happens that जा नहीं रहा है, मैं change कर देता हूँ. Lumen, nurses may change the lumen. Okay, so you must be certain by वो lumen वो use कर रहे हैं लोग. You understand the lumen? Then what is the fluid I'm going to use? Is the temperature right? Is the speed right? Is the consistency of that right? And then is the trace right? When you put all of these together and then you confirm 3 readings that have been within 15% of each other, then you have a reading that you can rely on. Then you have a reading which you can rely on. Clear on this till now? I hope I'm very clear. Because what happens is, you will be, most of your things you're going to do in your patient, you're going to completely depend on this particular reading. That's why you're putting it. We don't have an answer, that's why we're looking at this. And if you don't have the right values, you probably go the wrong way. Isn't it? Now in that, the next question that comes is, what do I look in this? इसमें देखो क्या? इतनी सारी चीजें तो बता दिया कि ये सब करते हैं, production आ गया है. So what do I look at this? So I do have few values which I'll clarify a little bit more further. She's tried her best to clarify, but I'll make it a little more easier. Okay. So the first value that I am very much interested in is cardiac output, which we know what is cardiac output now. We are taking it from Stewart-Hamilton equation and we are getting cardiac output. Wesley's equation is APCO. Okay, the arterial pulse control analysis. Whereas the main equation is Henry Stewart's equation, which is the Stewart-Hamilton equation. Okay, Stewart-Hamilton. This is the main equation. Stewart-Hamilton equation, which says temperature decay. Clear on this? Temperature decay. The other equation is based on arterial pulse contour analysis, which is Wesley's equation. Combined together, it gives you continuous cardiac output motion. Clear? Continuous cardiac output motion. So I'm interested in the next value that you see over there is called as global end diastolic volume. Now the GEDV is a very important value which is actually equal to the amount of fluid in your 4 chambers of your heart. In the 4 chambers of your heart, what you can see is global end diastolic. It's only the 4 chambers of your heart.
Yeah.
Not in the thorax. Only in the 4 chambers. Okay. Whereas ITBV is heart plus the pulmonary circulation. Clear? Alright.
Yeah.
So ITBV, or you can call it intrathoracic thermal volume. In Picco, it will come as ITTV. In Picco, it will come as intrathoracic thermal volume. This is what will come in your Picco monitors. Okay, when you do EV1000, it will come as ITBV. When you do indocyanine green, it will come as ITBV. Okay, so what we have Picco. So it will show ITTV. What is this? This is a combination of what is there in your entire lungs plus what is there in the hilum plus what is there in the heart. So lungs plus vasculature, hilar or vasculature plus heart. So it is showing you what is there in the heart, in the lungs, what is there in the lungs, what is there in the vasculature inside the body, inside that particular thorax, and what is there inside the heart. Clear on this? Huh? So this next step you get is pulmonary blood volume. So pulmonary blood volume is this outside. Is outside, which includes the hilum. Pulmonary blood volume. If I subtract this from this, I get extravascular lung water. समझ आ रहा है? Extravascular lung water is the water in the lungs, excluding the vasculature, excluding the heart. Excluding the vasculature, excluding the heart. Clear on this? Extravascular lung water is probably the best, I feel, best parameter that you can see in this because no other machine can give you extravascular lung water. No other machine can give you. Okay, so your echo will give you say fluid, but it will not tell you whether how much fluid is there, where it is there, what is there. This will give you a quantity. Okay, so there is something called as lung score. There is something called as lung score. Lung score is quantification of B lines and telling you this much may be the fluid. So they did compare lung score on ultrasound to extravascular lung water to gravimetric method. That means you know क्या किया Japan में, very interesting study, very interesting. Patient was dying. When the patient was dying, okay, Tagami करके एक आदमी, very beautiful studies it does. So patient was dying, just before death thermodynamics कर लिया. Just before death thermodynamics कर लिया, extravascular lung water निकाल दिया. Okay, उस same time पे अल्ट्रासाउंड किया. उसे में अल्ट्रासाउंड किया, अल्ट्रासाउंड करके कितना लंग वॉल्यूम और उसको लंग स्कोर में डाल दिया. And once that got over, patient died. After the patient died, he went and did a postmortem to figure out whether there is pulmonary edema and how much it is there by doing gravimetric method. What is gravimetric method? Lung निकाला, squeeze किया, पानी निकाला और देखा कितना है. Okay, so he did beautiful study, and what it says that extravascular lung water outshone everybody because the gravimetric method is the absolute method to understand. If you take the lung out, squeeze it out, how much water is coming out? That is exactly the amount of water in the lung, isn't it? When you dry off the lung. So when they actually compared ultrasound lung score with extravascular lung water was the closest to the gravimetric method. Extravascular lung water was closest to the gravimetric method. It's very, very beautiful study, and that's why there's a lot of promise to the use of extravascular lung water monitoring. Clear on this? Extravascular lung water. So it 100% tells you how much fluid is there, provided you have done all the steps properly. अगर तुमने steps बराबर बताए नहीं, then it is not that accurate. It has to have the steps that is accurate. Extravascular lung water. Clear?
Study name?
Tagami का study है. TAGAMI. Japanese study है. GAMI. Japan Japanese study on extravascular lung water. GAMI. Beautiful study actually. So extravascular lung water. So now GEDV is global interstitial volume. How does this GDV comes?
I was telling you the other button that you press, so where you get all the details.
Yeah, so once you get a first key, you in this main screen, you can get whatever values you want. You just have to change it. तुमको जो values चाहिए तुम उस पे दबा के निकाल लो वो values मेरे को चाहिए. So your main screen will get those values. If you don't want those values, take out this thing new values. So 8 values you can put over here. But if you want to have calculated values, like for example SVR or indexes, they are calculated. Indexes are calculated. Okay, to calculate you have to do press calculation button there, perform calculation. When you say perform calculation, you will get the indices like cardiac index. Now you will get GEDI, extravascular lung water index. You will get also when you say perform cal. Okay, you will get systemic vascular resistance. See SVR. SVR is a derived index. It is derived from cardiac output Mean arterial pressure.
times BP.
And most important, CVP.
Yeah.
Okay, a systemic vascular
CVP minus
resistance SVR is completely dependent on mean arterial pressure,
CVP.
cardiac output, and CVP, and that's why it's not something that I'm going to believe on, because my CVP has to be really right for that. You understand? My CVP cannot be inside my ventricle. My venous trace cannot be very close to the valves. Huh? My artery has to be right. Central venous line has to be really at the reflex of the pericardium. That's why the least of the things that I will look at would actually be SVR. Are you understanding? Because my central line trace or my central line location is very important to actually get my SVR. I still look at it. It's not that I won't look at it. But you understand the fallacies with the SVR? You understand the fallacy with SVR? Because it depends on the CVP. Since it depends on the CVP, it actually depends where your CVP is lying. Is it lying near the pericardial reflection? Is it lying in the ventricle? Where is it lying? You understand? So that's a problem. That's why SVR, you should be careful when you're interpreting your SVR. Why? Because you might look at noradrenaline and you say SVR is very high, let me reduce my noradrenaline. Don't do it like that, because it's very essential that the central line is in place to actually say that the SVR is that particular value that you're seeing over there. Clear? Samajh mein aa raha hai?
Yes.
Samajh mein aa raha hai? So now you have global end-diastolic volume, a fantastic value. This value tells you how much volume is there in the heart. So a hypovolemic patient, actual hypovolemic patient will actually have very low global end-diastolic volume. An actual hypovolemic patient will have very low global end-diastolic volume. Okay, it's not 100% like that, but you can say, okay, this patient's heart is looking hypercontratile. I am finding the extravascular lung water on the lower side. In proportion to that, the global end-diastolic volume is also low. So I am near about certain that this is hypovolemia. I am looking at. You cannot look at one value and say, okay, this is what it is. No. I am looking at everything together and saying, no, okay, this GDV is also low. It's 200. Maybe this is a problem. Let me find out what's happening here. You understand? GEDV. That's how I'm going to interpret my GEDV. So, a patient who's come in with intractable diarrhea and he has had in the night full diarrhea. Yesterday the GEDV was 700. Today it has become 200. Clearly you can think, no, कि भाई ये कल 400, 700 था अभी 200 हो गया है. So there is definite change in the GEDV, and that definite change in the GEDV in corresponding to that history gives me that indication that okay, maybe I should give him the fluid. And then what is the harm? I can actually look at extravascular lung volume. After doing a PLR, we're doing it in such a way that we're doing extravascular. Then we say, what has happened to the fluid? Is it gone into the lungs or is it gone into the circulation? We will know immediately after doing extravascular lung water. Someone married? GEDV. That's why I look at GEDV. Okay, the next thing I look at is usually cardiac function index, CFI. So it will come, CFI will come over there. Now what is the cardiac function index? It actually tells you the contractility of the heart. It tells you the contractility of the heart. So today your CFI was X, tomorrow it is different. You can understand the contractility is reducing or increasing by looking at just the CFI. Okay. However, it's not as accurate as GEDV or extravascular lung water. It's not as accurate as that. Okay, it's not as accurate because it is taking CFI from something called DP max. So if you were to open that value, there will be DP max on it. Can you see DP max on it? Open करके देखो. Is there?
In the calculatory one,
So in the calculation there will be something that comes as DP max. So it is looking at DP max, which will actually give you the cardiac function index. The DP max is not supposed to be very good. So I'm just telling you in order. Another thing that you can look at is PVPI, pulmonary vascular permeability index. Pulmonary vascular permeability index, PVPI. Is it there on that? See?
Yes.
Is there? PVPI. So PVPI is pulmonary vascular permeability index. Okay. Now what does the PVPI tell you? The PVPI tells you that in the event that your extravascular lung water is high, more than 10. When you say high, it's more than 10. Not 7 is like okay, but more than 10. Okay. If your extravascular lung water is more than 10 ml per kilogram, it is known to be in pulmonary edema. If it is more than 10, it is said that this is pulmonary edema. More than 7, 8, 9, it is not pulmonary edema. the volume content is 7, but it can go slightly higher. It has got some capacity to hold it. But once it goes more than 10 ml per kilogram, it now becomes pulmonary edema. It now becomes pulmonary edema, right? Now I want to figure out whether this pulmonary edema that is occurring is because of a capillary leak, or is it because of hydrostatic pulmonary edema, like for example fluid. Is it because it is the cardiac system is causing hydrostatic pulmonary edema, or is it just capillary leak? For that, I look at PVPI. So if the PVPI is less than 3 actually, PVPI is less than 3, this means that this is hydrostatic. If the PVPI is more than 3, it means it is leaky capillaries. Now how does this work? Say you have tomorrow a patient of dengue fever. Okay, a dengue fever has got different phases. The starting phase is fluid resuscitation phase. Then second or third phase it comes when the patient starts getting starting reperfusion. It actually goes back into the systems. All the fluid starts taking back all the water. So that time there can be a capillary leak. So what you are resuscitating 100 ml per hour, and then 2 days later this is going on. Third day, fourth day, ऐसा हो जाता है कि वो fluid edema हो जाएगा. Now you have to figure out whether this is because of my fluid or is it because he's leaking. Okay, you do this, you find extracellular amount to be high, you find this PVPI, stop the fluid, you will not give it anymore. You understand? So this can be used at various techniques, various ways. For example, I give a small fluid charge of 500 ml. I don't expect 500 ml to dilute 65 liters of my body and cause fluid overload. Right? If the heart is normal. 500 ml दे रहा थोड़ी ना वो 65 लीटर के अंदर घुस रहा है, थोड़ी ना कुछ प्रॉब्लम होने वाला है. Should not have a problem, right? लेकिन वो 500 ml दिया और fluid भर गया. You have to understand whether it is leaky or whether really the hydrostatic pressure is too high. You understand? So once I give a fluid challenge, I repeat my EVLW, I look at my PVPI, I can kind of understand, okay, it's not a problem. Are you understanding?
Yes.
Huh? That is if the EVLWI is high. EVLWI is a better marker of prognosis than your lactate also. Okay. What does the body do? Our body tries to keep most of the circulation inside the vascular compartment. We are fighting all through our life to get that water inside our vascular compartment. This is what we are doing. All of us sitting here, we are doing that. Our lymphatics work like that. Everything works like that. So if this starts moving out, means it is very, very diseased. So that's why the marker that is better than even lactate will be EVLWI. So if you have an EVLWI that is high to begin with, of course I would not want to do that to figure out prognosis. But say for example, if a patient in cardiac output monitoring and it is EVLWI and he found it to be high. You understand? Then the first thing would be what? Boss, this patient's prognosis is not very good. You understand? The prognosis is not very good. I need to act more faster, more aggressively. Clear? So these are all the parameters that are there on your monitor that will tell you when you're doing a Picco monitoring. Apart from this, it also gives you stroke volume variation, and it doesn't give you pulse pressure variation. It gives only stroke volume variation because it is not looking at pulse pressure. It's not looking at that. It's looking at only stroke volume. No, this volume is stroke volume. So the entire algorithm is stroke volume. So for pulse pressure variation, you have to use your normal arterial line from your monitor. From your normal films monitor, put PPV, it will come. Your PPV will start coming. So but the Picco per se will not give you PPV. For example, if you take a flow track monitor, you will not get PPV, you get SVV. You will not get PPV. Stroke volume variation. Of course, you can't use this stroke volume variation for anything. You can't use it for anything till you have all the characteristics that come in, which includes no arrhythmia. The heart is right ventricle is okay. There is no it is not ARDS kind of ventilation. There are large tidal volumes you are giving. Okay, and then only there is no pneumothorax. So these are the things you have to look at when you're actually doing SVV or PPV. That is the beauty of this monitor. The beauty of this monitor is all that so you can do it in arrhythmia, which you said is a contraindication. No, it's not. So what happens is when you are doing your first thermodilution, it will give you the most accurate report. When you're doing thermal, so this one, the arterial pulse contour analysis may not work in arrhythmia, but the thermodilution is gold standard for arrhythmia. So you understand what I'm saying?
Yeah.
So when you're doing thermodilution, you will actually get all your values. So you get point values you will get. Based on that values you can take your decisions, right? But you cannot take the value in the middle, it will not be accurate. Because that is looking at pulse contour.
There was a better pulse contour gain.
Yes. So the beach core values you may not be able to say that may not be accurate, but I can do my thermal dilution. I see my thermal dilution what's happening. Every 1 hour, every 2 hours I can do it to understand what is happening if I want to understand. Okay.
Yes.
Similarly, what happens when there is, say, a CRRT circuit? Provided you are, because there is a thermal dilution will occur, it will cause, provided you are not doing this, where you are putting the dialysis line not in the middle of your circuit, you can still do thermal dilution in a patient of CRRT. You are just looking at temperature decay, right? You are looking at temperature decay. The whole body's temperature in the CRRT circuit is reduced. Say it's 36 degrees. The whole body temperature of CRRT is 36 degrees reduced. I just want to find my decay. Provided my line is not in the middle of my injectant port and my thermistor. That same thing comes over there. So, what happens when there is ECMO? What happens when there is intermittent hemodialysis? So, if the blood pump flow, is more than 20% of the cardiac output, then you can't use this. If the blood pump flow is more than 20%, our flow in CRRT is 150 ml, so it's not a problem. You understand? But if the blood pump flow is more than 20%, it may become a problem. So the problem comes with ECMO. ECMO, the flows are 3 liters, and 2 liters, and 4 liters. These are the flows that you keep in ECMO. So maybe in ECMO you may not be able to use this. You may not be able to use it. But conventional CRRT you can use it, no problem. What about IBP? So IBP, what's happening is you have one good pulse, one IBP pulse. One good pulse, one IBP pulse. If it is 1:1. If you understand, so it is 1:1 of the rega. So you have one pulse and the second. This is what you're going to get. If it's 1:2, you're having one. This is what you're doing. 1:2. So if it is 1:1, means every pulse is getting augmented. Just multiplied by 2. Okay, you get the entire trace. If it is 1:2 multiplied, if it's 1:1 divided by half. If it's 1:2 multiplied by 2. It's you are seeing the same trace, just you're going to multiply it by 2. That's what it's going to. It's still going to pick up only the arterial trace. You understand? That's how you use it for IBP. So IBP is not a real contraindication. It's not a contraindication. You can use it provided you use the correction factor. You have to use a correction factor for it. So you can still use it with an IBP machine, but you should use a correction factor for it. Clear? I think we've gone through the entire. So you can stop this. So any questions on this?